Thanks all for joining our virtual grand round today. We're excited to hear from Dr. Hamad Abdel Hadi from Qatar. I'll let you start, Hamad, and please introduce yourself to everyone.
Welcome our Sudanese infectious disease colleague in infectious diseases or SIDA. أنا حمد عبد الجبار عبد الهادي أو حمد النيل. أنا بستخدم النيم حمد عبد الهادي as the Western name. أنا consultant في infectious disease adults في حمد medical corporation في دوحة. أنا mainly I done my training in the UK يعني almost for 20 years for junior and senior as well as a consultant, and then moved to the Gulf about 10 years ago. This is my background. We do more of clinical work. الجلف هنا we have different medical problems يعني compared to the West. Of interest actually, and I sort of instead of giving you a specific topic to give you sort of a flavor of the different cases we see in the Gulf. Khalid Dosa was intrigued by the sort of name of
Yes,
the
please.
presentation and he is a mixture. So Melange is French, and I don't speak French well. ولا كنت favorite of French. Like usually I use in my presentations and academic writing synonyms. You just look it at Google or at right clicking, it will give you options. So I like these names. And conundrums is a difficult or challenging cases. Some of them that might not be challenging. So I'm going to present 5 infectious disease tropical problems and the overview of the objective. I want to emphasize the importance of medical history during evaluation of infectious disease, and then to highlight the importance of pathogen identification during evaluation. And then, very importantly, I want to promote the importance of systematic and critical approach of challenging cases in infectious disease. And that is very important. So always we have to be very critical and to do detective work in infectious diseases. So the first case, usually we bring sort of an easy case as a start. This is a 55 male Egyptian patient, past medical history of hypertension, dyslipidemia, hepatitis C. His Hep C was treated about 3 years ago with, sustained virological response with no recurrence, so it's undetectable. He developed a very vague abdominal pains and had an ultrasound of the abdomen. The ultrasound showed a polyp, which has made some concerns. So his examination was normal. His normal blood, including LFTs, were normal. The ultrasound compared to a previous one showed that there is increased size of the polyp. It was 2 millimeter, now 6 millimeter with no biliary dilatation. So the surgeon, this patient came from the surgical team, they thought, he might have a gallbladder sort of neoplastic process. So they thought the best thing is to try to do, remove the gallbladder and then examine the histology. He had laparoscopic cholecystectomy, which was uneventful. And then he had sent for histology. So this is a histology, the top A. This is in large sort of magnification, and in the lower one, in the lower, high magnification, showing some pathology pointed as an arrow. Anybody want to suggest any potential spot diagnosis?
Schistosomiasis?
Schistosomiasis, and that is the one. So there is numerous, although you cannot see the sharp edge, sort of spine, but you can see the multiple schistosomiasis egg, most likely Mansoni, because it affects the GI, as you know. So this is a case of gallbladder schistosomiasis. So, when you get older like me, you will become interested in history of things rather than because people repeat the the clinical manifestation and presentation. So, but when you look at the history is very important. Schistosomiasis is very old. It's evolved with humankind. It was linked to Egypt historically. Linked to schistosomiasis is very old. It was written in the papers. It's been identified in mummies from the Egyptian sort of tombs. Bilhars, where the name bilharziasis, he studied almost for 10 years bilharzia in Egypt. That's why his name was linked to that, 1851. And Patrick Marson, Manson, you remember Manson book of infectious disease and tropical infectious diseases. These are the fathers of tropical medicine. And the name schistosomyces was suggested by a German sort of Austrian one called Wineland in 1855, and he drove it from the sort of schistos, which is Greek, means split, and soma, body. So depicting the shape of the mealworm, as you know, going inside the sort of the in the side. And braziquantel, we use it to treat all the types of schistosomiasis, developed actually in the 1970s, very old. But one of the interesting thing about braziquantel, as you know, is very well tolerated, and it has a very good safety profile, and usually have a short, you use it, as you know, you give it at once or two doses, and sometimes you might need it to repeat it in severe diseases. For example, the question we've been asked in this patient, shall we treat him? He got gallbladder cyst 2. Is it active? We tested the stool is negative, but we thought, praziquantel is very safe, so we gave him doses in case he had no reliable sort of treatment. And a lot of patients, from Egypt, also in Sudan, as you know, we have in central part of Sudan, in Jazeera area, big problem with schistosomiasis. So the first case was a case of gallbladder schistosomiasis. Um, Schistosomiasis is known to cause polyps in the GIT and the genitourinary systems, and the involvement of the gallbladder is very rare, although there is sort of written and described cases. And most likely the pathophysiology is granulomatous inflammation, which is propagate the growth of the polyps. You might think, what is the role of the hepatitis C? Maybe the hepatitis C is the cause of the polyps. We searched that actually. Hepatitis C causes increased metabolic activity, but not locked. And antiviral treatment are likely to cause gallbladder. Hepatitis B also had increased gallbladder disease. So if you are happy about the first case, anybody had any questions about the first case before I move on?
So he didn't have any eosinophilia, peripheral eosinophilia?
There was no, this was an incidental finding. So the bloods, were normal. There is no eosinophilia. So you might argue he did not have an active disease. Most likely this is a residual disease. But as you correctly mentioned, most parasitic disease is usually associated with eosinophilia, which is especially in active replicating sort of disease.
Dr. Hamad,
Okay.
I think it was a good thing that you treated him anyway, because I know that this parasite will like stay in the biliary tract and will lay these eggs, so you can't tell whether there's still like active schistosoma or no. So I think treating him was a good idea.
Also, we asked him, he didn't recollect any history of previous treatment. So that with
No.
schistosomiasis, if the patient does not give you a reliable history, I think with the safety of the praziquantel, I think it's better just to treat this is the easiest sort of option, and at least you ensure he had a recorded sort of established treatment.
Yes, and the polyp was growing, right? I mean, there was an increase in size, right?
Increase in size, exactly. Yeah.
Yeah.
So again, another thing.
Oh.
Okay, so I'll move here. So second case, this is a 49 Indian male, no significant past medical history. He had a 3 years history of progressive swelling of the dorsum of the foot and recollection of previous trauma at the site when farming in India. So he had a foot lesion, which is progressively getting bigger, and he recalled a previous trauma. And because of the increase of the size, he was in the country, I think, for 2 or 3 years before he presented, which has prompted his evaluation in ED, eventually referral to orthopedic surgery. So the clinical examination was unremarkable, and he had a non-tender nodular swelling extending in the first digital web space. There was a serous discharge expressed from the deep manipulation, because at the beginning, they thought it's most likely sort of a glioma or some sort of a cutaneous manifestation, a ganglion, infected cutaneous ganglion. So that's why they expressed the fluid and sent it for culture, which was negative. He had a normal, complete blood count, renal and liver function were normal. Even the inflammatory marker was not raised. the normal glucose and hemoglobin A1C and inflammatory markers were not raised. And this fluid, which was obtained from, by expressing, it was negative. So to show you this is a patient when it sort of came to our clinic. This is the sort of foot, and you can see even from this picture, there is sort of a protrusion between the first and the second toes. Anybody want to shout any possibilities?
Sounds like mycetoma food for me. I don't know.
Okay. Yeah, things which will support you, especially history is very important. If you have an acute, then you have to look at, for acute bacterial infection. But if you have a slow growing, long sort of nodular swelling, usually affecting sort of the periphery, like in the hand or in the foot, uh, you have to think of a chronic infection. The orthopedic surgeon, thoughtfully, as I will show you the MRI in the next slide, they feared he might have a neoplastic process, which is again something you have to put it in the working or the differential diagnosis. So the description: nodular swelling in the dorsum of the right foot overlying the first and the second metatarsal, with some skin discoloration. Just something for your. I remember the difference between coloration and discoloration. That this means abnormal. Yeah. So this is the MRI. Again, anybody want to chip in for the describing an abnormality? So I will proceed. As you can see with the arrow, you can see above and below. So definitely there is an abnormal shadow overlying the bone, abutting the first metatarsals. So there is a combination of soft tissue lesion and going into the deeper tissue. So as described in the radiologist, multilobulated soft tissue lesion overlying the distal part of the first metatarsal bones, eroding the base, suggestive of mycetoma, as Khalid correctly mentioned. So the surgeon, when they go on things like this, they send for histology because they thought it might be a tumor. Very rarely they send bacteriology, unfortunately, or fungal culture. As you know, we all have these problems with the surgical team. So anybody also want to shout about the abnormalities in the histology?
I don't know. Maybe I see sulfur granules.
Okay. The bottom, left hand side. What is stained? What's stained that? So you can see black. There is blackish, which is usually you use the GIMSA stain for general sort of bacteriology, but for mycology, as you know, you have to use the silver stain, which is, or Grocott stain, which is stained fungi black. So you can see, or even into the right, lower right, you can see there is something abnormal, something very rounded with very big sort of calculus. So the description for, always we have to rely by the clever histopathologist, numerous brown pigmented fungi or fungi, organism amidst a zone of marked acute inflammation, rounded, heavy pigmented thick wall fungal cells in the GIMS stain, and then in the BAS stain highlighted the fungal cells. So this is a difficult case. I think it's very difficult. All you can say it's a fungal mycetoma. So this is what you have to mention. So the description, the one in the right, as you can see, it's a mucosa of probably GIT. I like this sort of Godzilla type of shape, so it has nothing to do with the previous histology. But this is a description: necrotizing granulomatous inflammation, numerous brown pigmented fungal organism arranged in form of solid cluster of thick wall fungal cells. And there is organisms which is seen amidst a dense acute inflammation forming. It was a shame that is the surgeon team did not send culture so we can identify exactly what fungus was that. Somebody want to comment? Well,
Uh, Hi, I just entered. Could you just give me a brief about this fungus?
so this is a patient with 3 years is progressive swelling of the foot. He is from India, 49, and he came to the surgical team with what looks like, sort of, as Khalid mentioned, a slow growing nodular swelling, which is clinically myoclonic, but the surgeon were afraid of it could be a neoplastic. So they sent it for histology. This is the histology, sort of with the BAS stain showing a rounded sort of fungi. Heavy pigmented thick-walled fungal cell. Unfortunately, as I mentioned, it wasn't sent for culture. We only have the histology, but we have a very good histopathologist which is describe it, and we got the inflammation, the diagnosis actually from the histopathologist, and I took this from the internet. There is different fungi or fungi which are able to cause this condition. The most common one, the one in the right, Francisca bedrosi fungi, but there is others which is less common to cause this condition of mycetoma. As you know, mycetoma, there is 23 fungi what's able to cause mycetoma. So it's a very big sort of differential, and it is regional. So depending on North America, South America, or Mexico, South America, or India. This patient from India, so might be different from Sudan. So the description from this is spot by the histopathologist of chromoblastomycosis. As the name chromo means most likely it has to do something with color, and mycosis is a fungus. This is a melanized pigmented demataceous. Demataceous means pigmented fungi, CBM. It's very common in South America, actually. We only know this actually after we done our search. At the beginning of the 20th century, it has different names, but in 1992, they settled for chromoblastomycosis. Okay, so this is a diagnosis, mycetoma caused by chromo. And we have a very good, my colleague is called Dr. Saad here, is as equal to Dr. Welsh in America and Dennings in UK. Every country have a guru of mycology. So when we show him the slide, and he said, this is, I've seen many of them. So for us, it was the first part. So it was part of the mycetoma spectrum. It's a chronic granulomatous inflammation of the cutaneous and subcutaneous tissue. It's rare, but mainly reported from tropical and subtropical area. And as you know, most of the mycetoma, because they are environmental, it's mainly through inoculation. So you have to have a trauma, and people will barefooted, as it happened in Sudan, or farmers are at extreme risk. It responds to itraconazole. So this patient, we treated him actually in outpatient with itraconazole for 6 months, but usually best managed with surgery. So again, when he has surgery, and duration, depending on the level of extension. Ambisome doesn't work in chromoblastomycosis as the sort of different fungus. And if you done some search actually from Google, you will find it in South America, it causes extensive cutaneous disease. Very interesting. While in other part might cause deeper tissue. But the problem in South America is mainly of cutaneous disease. And again, if people leave it, it will cause very disfiguring sort of. Anybody want to ask anything about the second case of mycetoma secondary to chromoblastomycosis?
Ahmed, did the patient do well? I mean,
Did very well. Yeah, we finished. Because when the surgeon went in, they thought it was a tumor, so they removed as much as possible. Okay, because it was, as you know, mycetoma in a way it is a tumorous, isn't it? It's a swelling.
Yeah, it's
He had a surgical excision, and I remember he did not have a bone invasion. So there is erosion of the bone, but there is no bone involvement. And then we treated him for 6 months with itraconazole with good outcome. I have the difficult case later, so I will just move on. So this is a 27 Sudanese. She's shepherd from West Sudan. He had a chronic right hand swelling present for the last 12 months, initially evaluated and removed as a lipoma. So he's right-handed. This is at the sort of palm of the, the front of his right hand. And then he came to the plastic surgeons, our colleagues, done an MRI, complex, deep infiltrating lesion affecting the soft tissues, particularly around the right carpal bones and tendons. Um, they, when they saw him in, they knew there is something sort of chronic. So they asked us, can we treat him, and I said, in these cases, you cannot, you have to proceed for microbiology and histopathology. And again, I insisted when you're going in, you have to let us know because this case needed some liaison. They went in and they sent only sort of bacterial culture, which came back at negative, but there was no liaison, as I mentioned. So they asked us for help, and I said, unfortunately, you have to repeat. And when you do it next time, let us know so we can liaise things. I put this picture, which is, sort of reflecting what's sad happening about Sudan. This guy, actually, I really liked him because you can see, he's a young chap, maybe because of education, he's working as a chef, but he was very clever. His IQ was very high, definitely. And most likely, if he had sort of different paths, in life, he could have ended somewhere else. So this is the X-ray to the left-hand side. Even with the X-ray, as you know, you can see there is no bony erosions, but there is definitely soft tissue swelling, which is evident between the fingers. And in the MRI, very bad MRI, as you can see, mainly in the center, you cannot demark the sort of bone, the muscles, and you can see there is a very big sort of soft tissue mass affecting most of the palm of the hand. And then you have the spaces above that. So the involvement was mainly distal at the palm of the hand. So okay, so again, anybody want to chip for the differential or working diagnoses?
Uh,
Unlikely to be
I-
mycetoma again.
Yeah, I
yeah,
think, yeah. Again, you have to link the history. The history. This is, and I think one of the important thing in the history is the recurring. So they thought at the beginning it's a lipoma removed. He told me even he had a short courses of antibiotics. Actually, they gave him augmentin 2 weeks, but he never had two antibiotic more than 2 weeks. So the chronic recurring things, and I think neoplasm will be unlikely, isn't it? Because the
yeah.
history is long and if
What does
Hamad,
this guy do for living?
he's a shepherd. He's a he looks after animals. Yeah.
well, Hamad, because he mentioned Shepard, I thought of like Yaw's disease, YAWS. I mean, I don't know, this is treponema infection.
Okay.
Can be related
Um,
to sheep and
okay. His involvement with camel again. Remember, Anna, in the last cases I showed you the foot. Now is the hand. So I think he's from West Sudan, and we can we can say we can look at an infection. So for an infection, we could look at slow growing infection. TB also comes in here, isn't it? So TB of
yeah,
the hand, and also I think fungal infection. Neoplasm. Although we mentioned it's less likely, it's very unlikely to be a bacterial infection, isn't it? Because
Yeah.
sorry,
Hello,
food
Hamad.
bacterial infection. Yeah.
Hi, Hamad. Hi, Yusra here. Assalamu alaikum.
تفضل. يسري كيف حالك؟
Okay, well, I mean, that's quite ugly MRI. So, I mean, yeah, definitely bacteria is going to be unlikely. The bones looks pristine. And why is it so, different? The bones, so the excision was done on the dorsum of the hand or in the palm of the hand?
In the palm, yeah, they went
On the
front,
palm
yeah.
of the
So the
hand.
disease mainly affecting the soft tissue at the palm of the hand, yeah. So,
Okay, so I mean, yeah, if bacteria is out, it has to be a fungus or a mycobacterium of some sort.
yeah, I agree. Yeah, so this is, and for us, it's very difficult to change the approach of the surgeon. I've been doing this for many years. I think if the surgical team became very systematic in these cases, send TB, PCR culture, fungal culture, bacterial culture, and histopathology. If you do these cases this way, things will be very easy. But unfortunately, in reality, that doesn't happen. So this is the histology. Uh, we need sort of microbiologist or a histopathologist to spot. Anybody want to volunteer for a diagnosis? According
That
to my colleagues,
necrotizing granulomatous lesions?
okay, my colleagues, this is a very sort of obvious sort of thing. Now we learn it actually the hard way. So on the top one, this is sort of low power, and the right one in the middle, this is high power, and you can see there is the breakage of the very intense inflammation. This is lymphocytes, and in the middle you have this sort of filamentous with the breakage in the middle. So suppurative granulomatous inflammation with plasma and lymphocytic infiltration. At the center, there is a granuloma, numerous filamentous bacteria. So this is again the history, and this has happened, after we liaising with ID. So send it to histopathology, and again, I have to, we have our own channel to talk to microbiology, because last time, you remember when they sent it, the culture was negative at 48 hours. So you have to, these cases always, you have to liaise with microbiology. It is growing actually after in the fifth day on the left hand side, and on the right side. Anybody want to? If I say this is AFB acid fast negative,
Cardia?
nocardia will be
Nocardia or
AFB.
actinium?
Actinium, yes, filamentous, gram-positive, and being AFB sort of acid-fast negative, make nocardia less likely. So this is an actinomycosis. Yeah. So one of the important thing in these cases is to make sure you have to differentiate between fungal and bacterial, because the management could be completely different. So he grew in culture identified by the MALDI as Streptomyces fragii, which I'm going to touch on it. It's very sensitive, as you can see, only resistant to cotrimoxazole, amikacin sensitive, amoxicillin, clavulanic acid, and all the cephalosporin. So we have lots of option to go for the management of this patient. In fact, actually, we gave him an induction with a ceftriaxone 2 weeks. And then, because I think some people use one agent, but we treated him with augmentin and moxie. A right-handed person, I think we have to maximize his management for 6 months with good outcome, as I will show you later. So the left-hand side.
So what happened, Hamad? Last time, the time that he was treated, was it? You said never more than 2 weeks.
Exactly.
And every time he improved.
He didn't. They've done excision 2 weeks. It's very fragmented. It's not. It has to be so. It wasn't with us. Yeah, usually it was in Sudan. So this is going on for sort of almost 18 months.
No, I meant history-wise. Did he say whenever he's given antibiotic, he gets better?
He said he get better. Yes. Yeah.
All
He
right.
told me when he responded to antibiotic. It's a short course. It's a short, and as I mentioned, he was very clever. So he told me the antibiotic because this. So the picture on the left-hand side, you can see the ugly-looking MRI, which is used to mention, and this is after 6 months of antimicrobial therapy. Significant reduction of the, luckily he did not have significant bone involvement, mainly soft tissue sort of. Eventually, as you know, in these cases, if you don't treat it, eventually it will end up destroying the bone. And this is his hand actually after treatment, so after 6 months, and you can see at the palm of his hand the previous surgery, the opening and the debridement, and front and back. So clinically, he was doing well. So a few things about mycetoma, because it is rare. I sort of just to bring it to your eyes. It was first used at 1861 and derived from the Greek mushroom gross, which is usually cause chronic suppurative and granulomatous inflammation. As I mentioned, it is very, either fungi or bacteria. So you have to this bifurcation is very important, because if it is a fungus, you need to give antifungal, and if it is bacteria, you have to give antibacterial treatment. And the bacteria mainly caused by actinomycetoma and nocardia, so they already mentioned. So we have like 33 species causing the mycetoma. 23 are eumycetoma, 10 are actinomycetoma. So the bacteria is less likely compared to the fungal as in the first cases, as I mentioned. Fungal, as we know, is always difficult to treat. It needs prolonged treatment, while bacterial actually is favorable. So if you isolate a bacteria, then and you can look at PubMed or any sort of Medline sort of research. The research in mycetoma is very scarce. There is no randomized controlled trials to guide you of the best agent, because as you can see, I can choose any one of these agent on the treatment, duration of treatment. So this is all left for expert advice. As you can see, all the mycetoma, because it's one of the neglected tropical diseases. So you can treat depending on the complexity of the case. But pathogen identification is very integral. So you need to know whether you're dealing with a fungus or you're dealing with bacteria. And then if it is bacteria, you have to construct your regimen accordingly. So somebody might argue with me why you didn't treat him for 3 months, 9 months, 12 months. So you have to go with the responses. But I went for mid. Some people might treat for 3 months. I went because he's right-handed. We went for a 6 months. Just few things, as I mentioned, when you do your search to find out, the MALDI gave us Streptomyces freddii. So, we didn't know about it, so you have to Google it, and then you have to look at the papers. Streptomyces are the biggest, family in the actinomycetoma family. And it is found in soil environmental part. We just had our ID conference, and very interestingly, one of our colleagues actually mentioned vancomycin was brought from Borneo, actually. That's why it's called Streptomyces orientalis. So in the 1950s, vancomycin was extracted from Streptomyces for your interest. But this is Streptomyces freddii in particular, discovered in 1969 from Mount Montego in Spain. Okay, so it is from Spain. And they extracted both neomycin and phosphomycin from it. So the phosphomycin we use for UTIs and things, this came from this Streptomyces freddii. And in the literature, we couldn't find any reported cases of actinomycetoma caused by, you get excited, I'm going to write this. We're going to publish it eventually. We have the manuscript sort of written. We guess we need to go through it. But you have to do a rigor of streptomyces. So we have to do some search, genomic studies. This Streptomyces freddii is very closely linked to Streptomyces sudaniensis and Streptomyces somaliensis, as I will show in the next slide, with very good antimicrobial profile. So did the MALDI got it right? So I came across this paper to the left-hand side. This is phylogenetic tree, and it's showing both, Streptomyces sudaniensis and somaliensis. And freddii is very related to this. Remember, the MALDI is not a genomic, apparatus. So it will not look at the genomes. It look at the, protein profile of the organism. So it might mix it. To the right-hand side, this is a good paper looking at the genetic sort of profile of. This is from Sudan, by the way. This is Sudanese group, Dr. Ahmed Fahal or Prof. Fahal collaborating with Western sort of institute to do whole genome sequence of all the mycetoma type. So as you can see, so on the top, in here, Streptomyces sudaniensis and somaliensis, the yellow means less, resistant. So they are not associated with resistant to all the antibiotics except for cotrimazole. While Streptomyces maduri, if I usually remember in Sudan, it was one of the difficult, actinomycetomas to treat and associated with a lot of resistant genes. So I will bring to the right side the sensitivity for our patient. Very interesting, actually, to see is almost identical. So he was only resistant, this is Streptomyces, was only resistant to cotrimazole, which is coincide with the resistant genes from Sudan. So, which is made me conclude, if any, this patient had a mycetoma, most likely from Sudaniensis, so because he's from the west of Sudan. And I looked actually this morning at different papers, looking at, streptomyces from soil from Sudan done for research, and I couldn't find this streptomyces fragile being reported. So most likely, this is a misclassification from the Malditov. Before I move, I think uh, anybody who want to comment on this case, yeah.
Interesting, Hamad. So what are you gonna do? Are you gonna sequence it?
Um, on hindsight, yeah, Yusri. So you know the knowledge later, okay? So this is, you do it after you treat the patient and you do the literature review, and then you discover, oh, have I saved the sample to sequence it? On hindsight, and I thought it was straightforward, but eventually after a few months, you discover, after research. So on hindsight, I should have done that. But unfortunately, I don't think we saved the sample. We save blood cultures and things and MDR samples, but sample which is like fungus like this, we don't save it. And I will, I wish if I pursued this actually sort of actively at the time of the diagnosis, which is could have been of interest to prove, what was it. Yeah. And Yusri, as you already know, people move now in the importance of rapid pathogen identification and using genomics for diagnosis of difficult cases, because this is hopefully in the next 5 years in infectious disease it's going to come up front, to use genomics to improve your precision of diagnosis of infectious diseases. And this is sort of a typical case with if we improved. It will not, clinically it might not mention, but I think academically and intellectually, especially, I'm sure you've seen a lot of cases, people reporting weird things in the literature, saying this is the first case of that. But sometimes if you read the papers, you find they could have done this or that before they report this. And this is what we know sort of in academic integrity. So I move on for the fourth case, and I'm trying to, to stay with time. So just not to, I know all of you have other things to do. 35 Nepalese, previously was a farmer in Nepal, 2-day right-sided nasal epistaxis. So I forgot actually to give you a profile actually in the Gulf generally about the setup. The Gulf country, most of them, you have the nationals, the countries with the highest nationality, Saudi Arabia, and then UAE, and then sort of Bahrain and Qatar. And the majority on the other sort of three countries are expats, and these expats mainly from the Indian subcontinent, India, Pakistan, Bangladesh, and Nepal, as well as Asian patient from the Philippines. And then you have the Arab sort of, mixtures from the Middle East, and then part of Africa. This is very typical in all sort of, so it's very common to have a lot of patient from the Asian sort, or from either from Africa or from the Asian. So this is a Nepalese patient. He was a farmer in Nepal. He probably doing sort of this sort of blue coat working in the country. He came with epistaxis. He had no significant past medical history apart from mentioning a similar episode 1 year previously, treated with excision of a similar protruding mass, as I will show in the next minute. And then they gave him 1 year treatment with dapsone. So he said he came with epistaxis, with something protruding of his nose. And he said, I had it before, they took it off and they gave me treatment and came back. So he had a right-sided polypoid strawberry nasopharyngeal mass. Blood tests were unremarkable, including clotting. So you cannot, blame the clotting for the epistaxis. So most likely of what coming from his nose. A lot of colleagues from the Southeast or the Indian subcontinent, when they say this, they give me a spot diagnosis. Anybody want to? It is uncommon in Africa. To me, this is the first time I've seen it. I haven't seen something like this, but we are faced with this sort of different pathology.
Leishmaniasis. I know someone is
Yeah.
can go there.
Leishmaniasis, we had a case in the conference presented from Nepal with leishmaniasis. So, and I thought, is leishmaniasis in Nepal? And then I went and digged it. 13 countries, including, India, Pakistan, and so Nepal is mentioned with leishmaniasis. So there is a lot of leishmaniasis in Nepal. I wasn't aware of that. So in India, but it's understandable in the sort of leishmaniasis belt. So there is leishmaniasis. So this is a CT scan. As I pointed in the arrow, if you look at the left-hand side, the sort of sign, maxillary sinus is free, but in the right, there is a very big sort of protruding, even is deviating the septum, as you can see, this sort of opacification in the maxillary sinus, which is mainly soft tissue. As you can see, it doesn't have, it's very homogeneous, and it's deviating the nasal septum.
Dr. Hamad, you said they gave him Dapsone?
Okay, yes, and I will tell you the story about that. So why Dapsone? Okay, so what we went in, the bleeding, because he came as an emergency, severe sort of epistaxis. They backed him, and then they've done a functional endoscopic sinus procedure. They've done excisional, and then they took him to theater because it was a very big sort of mass. In the laboratory finding, polypoid friable mass. It's filling almost the right nasal cavity, attached to the inferior and middle turbinates, and it's very friable. It's bled very easily. They've done complete excision of the mass, then they have a partial inferior turbinectomy, and then they also done a sort of cauterization. So the surgeon, they knew this is something very abnormal. As I mentioned, in the Indian subcontinent, this is, as you can see, if you Google it, you'll find it very frequent. It was, again, the first case for me. So the histology of this case, people say it is pathognomonic. When you see this picture, I'm showing this histology. So for your future references, thick-walled sporangia. So you can see this is very sort of at various stages of development. So you can see the small, the medium, and the large size. And in high power, this is what is pathognomonic of this condition, numerous endospores within the sporangia, especially in the, this one, as you can see, there's a very big, it looks like a ball within, the histopathologist, because this is their job, especially, there was, one from India, when they said it's very easy for them. And the diagnosis is rhinosporidiosis. This is a condition. When we've done the search, it's a very rare enigmatic infection caused by Rhinosporidium cperi. It's a very hydrophilic organism. It oscillates in classification between parasite, fungi, and bacteria. Then subtle, they call it, when they do the sort of genomic study, it's an eukaryotic organism. The one who discovered it is called R. Sieber from Argentina, actually. This organism is about 100 years old, believe it or not. So, and it was revealed on aquatic eukaryotes. It affects both human and animals, so it can affect whales and things, and even horses and ducks and humans. And it also common in the tropical and subtropical area, and endemic regions. Is very common in the Indian subcontinent, as I mentioned, and it's associated with South America. And the transmission is linked to contact with fresh water. So people in stagnant lakes and ponds are affected. So swimming is a very sort of a risky sort of reason. And this organism grow very slowly, so it takes many years to cause problems. And because it is affect the mucous membrane, then every exposed mucous membrane. So when you Google it, you'll find it, rhinosporidiosis of the eye, of the mouse. You found it in the nasal cavity, even in the genital tracts. So when we search, because this patient had one year of Dapsone, there is no evidence base for it, but it has been mentioned in some of the case reports that Dapsone is effective. So that's why people did. But when we've done the search to treat this patient, we find that the best medical therapy is wide surgical excision and cauterizing to the basis. So you have to look at the stock and cut it and do cauterizing. And there is no role of medical treatment from the search we did. You cannot have sensitivity because it's very difficult to grow this organism. So we don't have any information about antimicrobial activity for this one. So I'm presenting a case of whenever you see a friable sort of strawberry swelling from patient, usually from the Southeast Asia, bled easily. This is rhinosporidiosis, an eukaryotic organism, and the best treatment or surgery. So if anybody want to comment.
Dr. Hamad, if this guy, for example, if I see a guy like this in a hospital with like immunocompromised status, I would think of rhinocerebral mucormycosis. It just causes the same like tissue invasion and sinus disease. So
So you are absolutely right. You know, especially in diabetic, poorly controlled or immunocompromised patient, and having sort of um, sinuses disease, you have to think about about mucor, which is usually, as you know, is very difficult to treat. Combined medical and surgical management with high morbidity as well as high mortality. Mucor, what it will be again? It's mucor. You know, the invasion of the blood vessels, which is can progress very quickly, and sometimes the blackish color of the mucor, as you can see in this case, was mainly sort of straw color cases. As I mentioned, this is for me. This was I never heard about it till we sort of managed these cases, which is interesting because you have to go and dig the literature and try to find out more about it. And you will see it actually in South America again. You know, into people in North America. You have a lot of link with South America. In Argentina and Brazil, a lot of cases like this. When I done the search, and to be honest, most of the good papers are coming from South America about the management. So you will see most cases of India and Sri Lanka, as well as Argentina and Brazil.
and Dr. Hamad, does it have like tendency to infiltrate the bone, like brain? Yeah. What if this is not treated? I mean, does it
No, not
follow the
really. Yeah,
same course?
yeah, it's mainly sort of mucus because it is not. I take it most likely it doesn't have significant virulent factors, so it will grow. And it's usually attached to a stalk in a mucus membrane. It's okay, so it's unlikely to to go and invade sort of deeper tissue. Most of the cases you can do it from papers you can see most of it goes it will be unsightly because it is protruding from the eyes or from the nose or the genital tracts, and it recurs. This is one of its problems. So if you don't do good excision, it tend to come back, but it's slowly growing. So people live with it because it is a very sort of, it take years to go big. And people, because it doesn't cause complication in the nose, it causes epistaxis. That's why so this patient, if it wasn't for the epistaxis, he wouldn't come to hospital. Okay, interesting.
Hamad, can I just comment on two things? One, the other nostril, the other sinus on the other side was pristine clean. So again, that is in infection. Normally, we expect things to kind of infect. At the time of inoculation, the two were done, or then local contagious kind of spread. So that was not there. So that again tells you something about it being not that infectious. Otherwise, it would have gone from the other side, maybe. The other thing you said is friable and it bleeds easily. So, and it's filling the nostril and turbinate. So does it like grow like a tumor, like a gumma with blood vessels within it? So whenever you remove something from it, it bleeds. It's almost like a tumor because if it's just in the stalk, I could understand that. But to be the lesion itself is bleeding, that means it's supplied by blood vessels itself.
It is. To be honest, I didn't look at its pathological section. Yeah, your comment is absolutely right. So it's in fact unilateral side. So you have to think, what make it sort of goes to a specific area. Was that area, for example, injured? Does it have like a previous injury to the mucous membrane for it to stick? Or what make it stick to one side rather than the even in the one, if you can Google them in the eye, you see they used to be unilateral, so it affect one eyelid compared to the right. So not both eyes, virulent. I think it's most likely it's not very sort of virulent organisms, not angiogenesis like sort of mucor is most likely less slow growing, but because it is growing bigger and it needs sort of vascularity, so I think it will reach some size, and then if it rupture or if it is broken, it bleeds. So this is my explanation, but it's very interesting. When I presented this, one of my Indians, you show them the picture, they just straight away they said this is rhinosporidiosis, but for us it looked like enigmatic, isn't it? Yeah. So I will go into for the to move to the last case for the sake of time, because this one is a difficult one, so I left it to the last. And I guess Sudanese, previously fit and well, worked in the airport as a driver in Doha here. No past medical history of NETIC and no medication. He last traveled to Sudan was 5 months ago, before the assessment. This patient, as you know, very common here in the Gulf, the patient does not go from A, B, C, they go usually from Z to A. So he came to me from the pulmonology, hematology, oncology in March 21 during the COVID restriction. Everything was very difficult. So this patient basically chronic cough with lung involvement, abnormal chest X-ray associated with a skin lesion in form of nodules and ulcer in addition. So you can see, why he went to pulmonology. They thought lung cancer. Why he came from hematology, oncology. Does he have a lung tumor with a skin infiltration? This was the working on diagnosis. Um, Very weird cutaneous lesion with lymph node enlargement in the lungs. And they thought that this was definitely carcinomatosis. So they went in with bronchoscopy, EBUS, biopsies. And when they have granulomatous inflammation, they refer him sort of to me, is this could be infective. So this was the working. I hope I summarized the case well. So somebody 45, previously fit and well, he coming with progressive cough, abnormal chest X-ray, as I will show you, and then skin lesions. So the cutaneous pulmonary lesions. And this is the chest X-ray. If you agree with me, mainly on the right side, it looked like cannonballs, isn't it? It's very big, sort of widespread. There is also left-sided lung involvement, as you can see on the left hand, and just above the hilum. So very sort of abnormal, poorly defined nodular opacities at the right lower zones and then paracardiac shadow. And this is a CT scan to augment what I said. As you can see, there is multiple lung lesions in the lung window. We also had pleural effusion. The one to the right is more than the left. So it's very weird sort of presentation. And I will show you the skin lesion in a minute. So things start with a history. Although he came, this is probably lung cancer. So we have to take a detailed history. Multiple painless chronic skin nodules in the arms and leg, then breaks into ulcer, followed by the chronic cough. So he said the skin lesion was first, and then the lung lesion was later. I start with the nodule, which is break. And he said he started 1 month after return from Sudan. He is from the west of Sudan, which is interesting, as I will discuss later. Progressive non-healing and not responding to local oral antibiotic. He came 5-6 months with this lesion. He had no history of TB or no family history of TB, but he mentioned his father had hematological problems. It looked like Castleman. I looked at, he'd been followed under our cancer surface, so maybe there is a genetic element. I will come to that in the end, associated to this. So this is the lesion. The one to the right, this is the nodules, and then after they break, wet, and with the rim with the discoloration around it. Okay. Anybody want to suggest any possibilities based till now about the history and the presentations?
How was his HIV testing?
HIV. Okay, let me just for the sake of the investigation, and I always advocate this history, examination, and investigation. So his complete blood count is more normal. His liver, he got total protein is high, albumin is low, CRP 45, very modest, ferritin is not very high, diabetes is okay, HIV negative, his ANA and ANCA is negative. So unremarkable inflammatory response. You cannot make anything of the bloods. Even things like lymphoma and leukemia, as you can see, his blood parameters might not support that, if you agree. Okay, I'll move on. So just to show you the workup for this patient. He has this from the lesion negative for bacterial organisms. Initially, there was negative fungal elements. So when they've done microscopy, there is no fungal elements. But as you can see, you do it for extended. This is when I send it to the lab asking for fungal culture. So Eurobasidium blulens. This is the moldy keep tricking us. We Googled it as usual. Yeast-like, they said it's very common in the environment. Is it a contaminant or a true pathogen? And remember, this is a yeast. If crypto come in the differential actually. We had a cases of pulmonary cryptococcosis in immunocompetent in some patients. But this patient HIV negative, is this lung lesion is crypto? Again, did anybody seen sort of ulcers with crypto as aggressive like this? It's usually sort of maculobubulars and diffuse. We've done from the lesion AFP smear and culture negative. We've done TB PCR negative. We've done sort of ball and lymph node. All the TB workup is negative. Okay, syphilis.
Was that by nodule or the ulcer?
Say it again.
Were this culture obtained from a nodule or an ulcer?
From the ulcer. Yeah. So we didn't stick a needle in the nodule. So we took it from the different. We've done it different parts. So because as you know, in these cases, you don't know where the pathology is. So we've done maybe 5 or 6 TB workup because TB fits very well. I will show up a slide on that. Pulmonary and cutaneous involvement. But is the skin lesion are typical for TB? So histology and cytology, people might be interested of that. The CT and endobronchial ultrasound with mediastinal lymph node biopsy, non-necrotizing lymphadenitis, AFB negative, fungal negative, Giemsa stain negative, no neoplastic process. The skin biopsy he had, I will show you more than more multiple biopsies, all non-necrotizing granulomatous inflammation, AFB negative, fungal negative, Giemsa stain negative. People might think of leishmaniasis from his Sudan, and as you know, skin biopsy is one of the easiest way to diagnose cutaneous leishmaniasis. There is no Leishman-Donovan bodies. The BAL cytology, no malignant cells. Neoplasm, negative for malignancy, lymphoma. We've done, flow cytometry. It doesn't fit with lymphoma. So a tough case. I sort of, I deliberated with one of my mentors about this case because of difficult case. And always, we learn every time. So it's very important to classify ulcers and to know them. For example, it's pressure neuropathic ulcers. We have the infectious. TB tend to cause undermounted ulcers. So you can see there is a shelf for the TB. Buruli for a mycobacterium other than TB like Buruli. In Sudan, I never remember seeing a case of mycobacterium ulcerans. As you know, poorly malnourished. It is very rare, but it most probably happened in the south of Sudan. I don't remember we've seen a case of Buruli ulcer in the north. Mycobacterium marinum, we've seen it actually, people working with fish tanks. And the nodules is different. Actually, I remember, if you remember, Dr. Snow was very fond of these cases. It has this purple hue around, and people usually working with in fish tanks to develop the Mycobacterium marinum. And TB lupus vulgaris, even the cases are different. Then you have the inflammatory vasculitis, like Bioderma gangrenosum and cryoglobulinemia. The lesion is usually painful because it's intense inflammation. So, and the lesion can be of any shape depending on the vasculitis. And then in the neoplasm, you have the primary squamous cell carcinoma, the basal cell carcinoma, lymphoma, and leukemic infiltration. And this could be of various sizes. And most of you, because this is very common, the vascular ulcers, you've seen it very frequently. So where shall we fit this patient, ulcers in the right with this differential? Does it fit with TB? does it fit with somebody suggests it could be, so sometimes syphilitic gamma test, but as you remember, his RBR is only 1 in 1. Is this, goes with, I think people might find it very unlikely. Is this inflammatory vasculitis, or is it cancer? So just to summarize, this is a gentleman who was previously fit and well, came from Sudan, painful, progressive skin nodule, which is break into ulcers, and then had a cough and lung nodules, okay? Very weird presentation.
But it looks, Hamad, the ulcers look like a pyoderma gangrenosum. I mean, that's the first thing that came to my mind when I saw it. I thought, but it's a little bit too chronic for that. But it's
no
painful.
systemic disease.
It looks like a
pyoderma. Yeah, he has no systemic disease,
Yes, but I don't know how can I link it to what's happening in the lungs.
Are they painful? Salam alaikum.
Yes, they are painful. Yes.
It's not painful at all. Very painless.
They're not painful. That's why.
Painless. Yeah.
Painless. That's so that makes pyoderma not off the list. But they did look like pyoderma. I was trying to type, and then you shouted out pyoderma.
Absolutely. Absolutely. Yes.
And with pyoderma, you can have lesions in the lungs that look like that.
Okay, vasculitis. What about Leishmania, Yusri? I'm sure you've seen previous or
yeah. I mean, I've seen the post Leishmania, the post-dermal leishmaniasis. I mean, the punched out ones are more like this, but the ulcers just do not look like it at all. And again, how could that be linked to the lesion that is shown in the lungs with a pleural effusion as well? I haven't seen that.
Very, very, very weird. Yeah. So I just made a summary for the differential, if you agree. When I saw this patient, I thought this is leishmaniasis, fitting with the history. Travel, he went to Sudan, endemic area, came with typical skin lesion, chronic non-healing ulcers. But one thing which is against it is the lung involvement, which doesn't fit with the cutaneous disease. There is a visceral leishmaniasis, there is lung involvement. This has been well reported. We've done multiple serology in this patient because I was very convinced there is a visceral component to this, negative serology for Leishmania. And this is an important teaching. So you have to do the detective work. The serology, which is done in most areas actually for Leishmaniasis, is based on the RK39 antigen, which is only present in Leishmania donovan, so which is called the visceral. So the cutaneous disease, which is Leishmania major and others, for example, Braziliensis and Mexicanus, it tend to cause it will be serology negative. So when you're doing the serology for Leishmaniasis, you are only tackling visceral Leishmaniasis. So, and this RK39, this is a 39 sequence of amino acids. So it's important to understand, if you want the sensitivity and the specificity of this test, you need to know, how it's made. Then you have to think about TB, including non-tuberculous mycobacteria. It's from an endemic area, lung and skin involvement, chronic non-healing ulcers. But the skin lesions are not typical of TB. We never got TB from anywhere, from culture, from BCR, and people, as sort of in the TB BCR only detect MTB, and Bovis doesn't detect other MOTTs. But they should grow either slow grower or rapid growers. So there is something wrong. Does it have a fungal infection? Things like histoplasmosis, Penicillium, cryptococcal, or blastomycosis. If this is from America, they will be very excited about this. But you got lung and skin involvement, which is fit with fungal, chronic non-healing ulcers. What is the relevance of this isolysis, bullosa? Is it a tip, but there is no typical travel history, negative HIV test, negative culture and histology. We never got any fungal from the histology. So you cannot associate the one you grow with the histology. Vasculitis, bioderma, both Yusri and Nidal cover this well. Lung and skin involvement, chronic non-healing ulcer, but he got a negative ANA. Even his CRB was 45, no typical ulcer. And it's not painful. And then could it be a neoplasm, like lung neoplasm with skin involvement, lymphoproliferative disease, and then lung and skin involvement, chronic non-healing ulcers. But he's very stable, and negative histology from the EBUS, from the lymph node, everywhere when negative.
Dr. Hamad?
So
Just,
yes.
just one thing. So speaking about leishmaniasis, I mean, I know you still mentioned the post-colorizar dermal leishmaniasis. I mean, this guy has no colors out, so that's first thing. And the other thing is, was he exposed to this sand fly? Because I know this fly is like really nasty, and when people get bitten by it, it's usually like very painful, and people would recall. So does he recall any like sand fly exposure or any bite? Sorry.
I asked him about insect bites. He said, he had, as you know, people travel to Sudan. He always had been. But what is interesting in the history is this lesion, just came, just after he came from Sudan, and they start with a nodule and then break, which is, I remember, we are older than you. You are very young. In the 1980s, there was an outbreak of leishmaniasis in Sudan, and and I could from the Roman. I've seen, lots of my colleagues, I myself, I didn't have it, but lots of young, sort of adults who are outside bitten by the sandfly. Typically start with an endure, then break up, and sometimes it heals without treatment, if you remember, Yusri. And, and sometimes you need a medical treatment. So,
So Hamad, if you can just allow me to comment on what Khalid has said about recalling that you've bitten, that is absolutely not true. I mean, in that outbreak that Hamad is just talking about, I had two lesions. One of them was in my middle finger on the left hand, and it started the same way Hamad described it. I didn't know what it was, and then it became an ulcer, and it's not as big as this one in the picture, but it's like an inverted V-shaped thing, and it was a nightmare, and it took months before it healed. Then I had another one while I had that one on my ankle, and I knew it straight away by that time because I've learned the lesson. And I was sitting with a friend, just having a cup of tea in the college, while the friend had a fag, and I just, as soon as I looked at it and I knew it was, so I took his cigarette from his hand, and I put it out on the ulcer, so I cauterized the ulcer, and the diameter of the cigarette was bigger than the ulcer, so I roasted it completely, and it healed much quicker. 5 days later, the burn has healed, and I didn't have another big ulcer of cutaneous leishmaniasis. That's my anecdote.
Yeah, but you still remember the ulcer, right? I mean,
okay. Yeah, this is just to tell you, so the history of medicine. So I was very sort of fixated about leishmania, and so I tried very hard to prove that we have a good parasitologist in the lab. Again, in leishmania, sort of in Sudan, the best thing, you can aspirate around the ulcer, but the same thing you do, you can do a wet preparation. So you have to do scraping around the ulcers, and then you do a wet preparation by scraping to look for the typical, they call it, I remember what is the professor from St. Thomas, he calls use it to the blue dot disease. He was a very big sort of histopathologist. Lucas, yeah, you are right. Yeah, he called it the blue dot disease. So to see the leishmania A mastigota in the game sustain. And histopathologists like it. So if you look at these dots inside the macrophage, because the bromates to get infected macrophages, so if you see them in the wet preparation, this is pathognomonic. So excitedly, it takes a lot of arrangement to bring the patient and to do the wet preparation, but no visualized leishmanian body. So what would you do? I will ask you the question. You had this patient. We've gone through this differential. Remember, almost 6-7 months since the start of his symptoms. Okay. So what people would do with this patient? We never, not TB, no leishmania, no neoplasm, no vasculitis. What is the pragmatic approach? What you gonna do?
so Hamad, I don't know, but I mean, if the patient was here, we'll get another biopsy and send for like 16S RNA.
Okay, that is a very good thought. Genomic
Or 18S.
or 18S. Yes, that is again, yeah. It's a very good. Yeah. Okay. Remember, we've done CT scan guided biopsy, we've done EBUS, we've done multiple skin biopsies. We've done we sampled the lymph node, we sampled the lesions. It's only just granuloma. We couldn't, it's not cancer, it's not infection. We couldn't, or not no TB. So it needed sort of some of a pragmatic approach. So I admitted him to hospital, and I thought, liaise with dermatology to take multiple skin biopsy from the nodules and from the ulcers edges, because I was fixated. We're going to get an answer. No answer. As Yusri and Khalid is, we don't have an in-house 16 RNA, but our colleague at the university sort of, we've done a 16S and the 18S, both negative. Okay, and now actually we managed to have the, what is your comment, Yusri, about the utility of the 16S and 18S? Do you think they are helpful, or is there any way of improving its diagnostic ability?
Well, I mean, it can be very, very helpful, especially if the samples are taken from an area where, you're not expecting polymicrobial disease. So when we use it for CSFs and joint fluids and that kind of thing, valve tissues, they're very useful. I'm sure Ahmed will also agree with me. So, but once this thing is a polymicrobial, then it becomes less. But they're definitely, I find them these days, until now, maybe until we get better pipelines, more the yield is better than the yield that we get from next generation sequencing or metagenomics, where it's just difficult to arrange and the results are difficult to interpret. But yeah, I if you choose the right sample, yes, they're useful.
Yes, yes, Dr. Yusri, this is right. Actually, I just looked into this like lately. The highest yield, which is you get a sensitivity around 50s. If you get a tissue biopsy, as Yusri mentioned, when you get tissue, the yield is much more than fluid, and it's like in the 50s, especially with the heart valves and core samples. Yeah.
Yeah, I took it from the biopsy. I think your point are very valid. We took culture negative endocarditis, the best yields with genomics with the tissues. So we took it from the, one of the sort of biopsies. So we processed the biopsy rather than the swabs and things. But again, I was very disappointed. I was thinking maybe this patient had a different type of, leishmania. This is my. I also discussed it yesterday with Prof. Ahmad Mudawi, and we have an immunologist in Will Cornell. So in these difficult cases, always is better to collaborate with colleagues to try to find an answer. I was thinking maybe he has something completely sort of different. I thought the genomics will answer the question, but it didn't. So I think this patient been going on a lot of investigation. So the pragmatic.
Ahmed, can I just comment on the 16S?
Yeah.
I mean, I wasn't expecting the 16S to work for leishmaniasis very well anyway. So I mean, because it seems like it was your favorite differential, and it probably mine too. You persuaded me. I would have just gone for a leishmania specific PCR, just for a leishmania specific PCR, and there are now good ones, generic ones that people could just use, and that could maybe help rather than try to do a generic or a genomic test that could pick it up.
Very valid point, Yusri. I take it, I explore that. We have got Nahla from Qatar University, but she told me, unfortunately, they don't have a leishmania specific PCR. Will Cornell also. I was exploring actually to send a sample in Sudan. I thought the Institute of Endemic Diseases are very good, and they might have a better experience with that. But the logistic of that was difficult. Your point is very valid. Sort of if you have a leishmania PCR. Remember, leishmania is very rare in this region. Saudi Arabia, they have more cases than in Qatar actually. We don't diagnose, and most of the cases are cutaneous, which is easy to treat. We don't have difficult cases like this. So just because for the sake of time, I know a lot of you have other things to do. So I thought, the best approach of this patient is to give him ambisome and see his response. We treat him with an induction for a visceral leishmaniasis regimen, 40 milligram per kilogram with repeated doses. And we sort of to see what is the response. So within few weeks, there is complete resolution of the skin lesions. We've done a CT scan after 2 months, complete resolution of the pleural effusion disappeared. The lung region replaced, but not completely. And like typical, as you know, with our cohort of patients, when they get them better, they disappeared. So he's well. Just to complete my rigor, I phoned him actually, and I said, "Are you well?" He said he's very well, asymptomatic, and he probably said he will come to visit. I'm very keen to do a repeat CT scan of him just to ensure there is complete resolution of the lung lesion, because that will augment my feeling he got a cutaneous leishmaniasis, most likely with lung involvement, without me able to prove this. I'm going to skip this just for the sake of time. I think people know very well about leishmaniasis. William Leishman, and it's mainly in specific countries, 90% of cases in 13 countries. And we see it in Sudan and South Sudan. And as you know, the name Kalazar, the black fever, came from India. And we have the cutaneous, the mucocutaneous, and the visceral leishmaniasis. And we have the Leishmania belt. And you have the New World, the Old World, the Mexicanus, and we have the even we have Leishmania, I think Sudaniensis at one of these things. So again, we dig the literature. Can you have lung involvement with visceral leishmaniasis? This is an interesting case from Liverpool School of Tropical Medicine. A Sudanese guy came with hemoptysis, and then they treated him for TB actually for a year, and he was symptomatic, and eventually they've done bronchoscopy to discover Leishmania donovani. The serology in our case was negative. Okay, so and then I recalled, what happened with his father. His father got Castleman's because this paper talked about imbalance about T helper cells and T helper 2 leading to, because the shift, you can have the cutaneous lesion can progress to become a visceral leishmaniasis actually in some patient, and most likely this is immune related. Is there is genetic predisposition in this patient? I think this is something to think of. I think with that, I finish here. I guess I want to thank actually, I have a Sudanese colleague, junior colleague, actually, both couple Jawahir and Wail. These cases came to the clinic, and I was very dubious about taking them forward, but as young researchers, they said this is very interesting cases, we should take it forward. So we eventually published it. I think our Prof. Ahmad Muhammad Al-Hassan, he was a very pioneering leader. We cannot mention leishmaniasis. We all have enjoyed his lectures, magnificent, vivid lecture about leishmaniasis. One of my mentor when I started IDS, Nick Beeching, he was one of the gurus of infection, a very good clinician. And actually, he discussed with me the ulcers. So this is what I showed actually to try to decipher this case. I think with that, I stop if anybody wants to make any comments here.
Thank you, Hamad. This was a fabulous talk. Thank you very much. And the floor is open for anybody if they have any questions.
Hamad, I'm really really impressed that you end up starting the amphotericin B. I mean, if this patient was like taking care, he's lucky like that he had you, because if this patient, for example, was here, probably like end up with like non-infectious granuloma diagnosis, and then I don't think anybody will like start amphotericin B here. But I mean, it's good to have somebody who's experienced taking care of these patients. So
it's not. I'm a very pragmatic physician. You have to think, what would you gonna do? Okay. So, you're going nowhere. I've investigated him as an outpatient almost for, me personally for a month. Colleagues, 2 to 3 months. He's been going through clinics, one clinic, one procedure to the next, without establishing a diagnosis. Yeah. I cannot call this case definite leishmaniasis, cutaneous with lung involvement. I cannot do so. I can say probable. Okay. Because even I was very surprised. I couldn't find it in histology. We couldn't find it in by any means. But I think his response to treatment, as people might say, he might have another fungal infection, and he responded to ambisome. That is quite reasonable. But why you cannot see the fungus in histology, or you cannot grow it? This is again an interesting counter argument. Yeah.
Well, you saved his life, which is good.
Yeah, these cases, yeah, I was very sort of like, all of us in our career, we have tough cases, where you don't know, what to do. But I think one of the lessons, whenever you have a very difficult case, it's very important to deliberate with colleagues and experts in the field to try to, I think I turn every corner with this patient. I don't think there is anything. If I have the resources, we could have done more. Yeah, for example, I explored with colleague in the university to look at his immunology because he must have something. The paper from Liverpool School of Tropical Medicine, if you read it, it's very good. They've done a lot of, T cell function. They've done a lot of, but you need this as a tool of research to try to prove he got immune dysfunction, which is caused progression of. Because that paper is very good. They looked and they discovered that patient had an immune dysfunction, which is probably led to his lung involvement. Yeah. So if I think no further comment, is that then if you want
So,
to
Hamad, my hands are up. Just wanted
okay,
to
sorry,
say
I cannot see it. Obviously, I cannot see it.
yeah, thank you very much for the talk and the cases. Very, very interesting as usual. Actually, I want to have a consultation now. uh, I've got a couple of patients. The first one was a lung lesion, central lung lesion, and referred to me as acquired tuberculosis, a bladder carcinoma on BCG, given a few months ago. So they thought it could be disseminated or something, and they sent him to us. And then they did BL, and they took tissues, and the tissues grew a pseudo Aliceria boydii, which is a mastoma kind of organism. So I have seen it only in feet in the UK and in Sudan. So I don't know anybody has seen a pseudo Aliceria or which is a pseudosporium causing something like this. So at the end I had just to go with that and give him treatment, and he's getting better. He wasn't symptomatic in the first place, but radiologically he's improving. So that was a question just for people, because I thought could be contaminant or could be anything just there or not, or colonizer, because it's an environmental organism. So that is one. The other one is a 15-year-old post-bone marrow transplant who came in well with fevers and everything, and then they sent a urine sample, and he showed a Cladiophilofora bantiana fungus from the urine. And again, I just like you, I went and tried to look what this organism is, and I found loads of brain abscesses. It's a completely CNS tropic fungus. All the 70-something cases that are reported in the literature are all brain abscesses. But it was from the urine, not from his not from a CSF or from a CNS sample. And then went back to him, and he said, "Yes, I have got a headache." So we did an MRI today, and he's got small frontal abscesses, very small ones. Yes. So again, what would you do? Do you go for a biopsy for that, or do you just treat? And why is it in the urine? Anybody have got any information about this Bantiana or Cladiophora?
In both cases, I don't have, I didn't came across them. But the first case, did you do histology when you do the lungs? Did you do any histology? Because actinomycosis in the histology is very characteristic, invasive one here. So you isolated bacteriologically, but did you isolate it histologically?
No, I don't think so. The histology, I can't remember histology. I think it was just a non-specific inflammation rather than a characteristic finding.
The first case is relatively easy, because you are stuck, probably going to treat the patient and then look at the, radiological improvement. So if it is regressing in serial CT scan, then, you have at least something to do with. The immunocompromised patient, as you know, they are always very difficult. Anything, the dictum with this patient, anything can happen. And I think with the lung, with the CNS, did you do a lumbar puncture or no? Because you're trying to see whether it will help.
No. I mean, actually, it was from the urine, as I said, the culture.
No, but
And
after the
because I
MRI,
didn't know much about the the fungus in the first place, I went back and I found that actually there were many cases, and from our own center here in King Faisal, they had a series a few years ago of brain abscesses from the same organism. So it's not so uncommon, it seems like, in arid, very hot areas here in Arizona or in Brazil or in the UK, in KSA. So once I presented, they said, "Oh yeah, this must be a brain abscess." But he wasn't. He did not present with that at all, and it was picked incidentally in the urine culture. And we went back and asked him the history, and we went back and did the imaging of the brain, and to find only these small abscess-like abnormalities. So it's just a weird part of infectious disease.
Most of these things is regional, isn't it? Is anybody of the colleagues in transplant infectious disease? Because this will be interesting of how they can approach this.
I don't think anybody is here. But these are like really difficult cases.
I think usually, the neurosurgeon will not entertain going to a patient with multiple lesions and immunocompromised. This is from my experience, unless there is something very obvious or the yield, unfortunately, of lumbar puncture with brain abscess is very low. But it might worth a shot to see whether you can grow something from the CSF, because you need pathogen identification. I always go for pathogen identification to confirm. And then if you are stuck, you might end up treating the patient and then look at the resolution of MRI, to repeat it maybe every 2 to 3 weeks to see whether they are getting smaller, which can improve your precision of this patient is improving or not.
Yeah, I'll probably do that. Thanks.
I have a question, if you don't mind. You said that the organism also like grows from the urine, right? So
it was
like, huh?
It was grown from the urine.
Yeah, it's like, it means that there is something in the bladder or the NGO system. It necessitates like doing a scanning for this area.
Yes, we did the scan, but there was nothing there. There was no fungal ball or any sign of pyelonephritis. There was nothing there. But what had happened, the kid had a problem previously because of his lymphoma, and he had a nephrostomy tube inserted prior to this in the previous admission, and it was removed after that, after he had chemotherapy. So there was some manipulation of that kidney beforehand, but the imaging did not show any current abnormality.
One of the things, especially with, as you know, with the multi-organ involvement, it's important to do an echo. So, just to make sure, it's not an infective endocarditis throwing into the urine and in the brain. So although, I have no opinion with that organism.
I'm not happy with the organism causing 2 problems. So, I don't want a third one.
It's unfortunate, the transplant, and sort of, it's not my cup of tea. So
yeah,
this is a difficult.
That's fantastic. Thank you very much for the presentation, Hamad.
Okay, thank you. Or I correct myself, immunocompromised sort of post-cancer patient. So thank you everybody for attending. I hope sort of I gave you some sort of a glimpse of tropical infections, and it will provoke some talks and give you some flavor of interesting cases which will help you to manage your patient in the future, inshallah. And thank you, for organizing this. It's taken a lot of time and effort. We understand that. So thank you very much for continuing the torch of knowledge.
Thank you, Hamad, for the interesting presentation. And thank you to all who attended today. And we hope to see you all next month in our virtual grand round. It will be first Sunday of the month at 9 a.m. Central Time. See you all. Thank you very much.